Welcome to this ASN Kidney 360 podcast. I am Kandil Sumro, an assistant professor in the Division of Nephrology at NYU School of Medicine. Today I will be discussing our study published in Kidney 360 titled Phenotyping of Heart Failure in CKD using electrocardiographic features. We wanted to know whether features from a routine 12-lead electrocardiogram can predict new-onset heart failure in people with chronic kidney disease. The motivation was practical. ECGs are cheap, fast, and already part of routine care. If they carry an early signal for heart failure, that's a low-cost way to risk stratify a population that already has a very high cardiovascular burden. We used the NYU ECG database linked to electronic health records from 2012 through 2021 and assembled a cohort of adults with established CKD and no prior heart failure. The primary outcome was first heart failure hospitalization occurring at least 30 days after the index ECG. Identified from primary discharge ICD-10 codes. We used lasso penalized Cox regression to select predictors and fine-grain competing risk models as a sensitivity analysis, treating death and end-stage kidney disease as competing events. In a cohort of 11,409 patients with CKD, about 8% developed heart failure over a median follow-up of roughly 2.5 years. 3 standard ECG features came out as independent predictors after lasso selection: PR interval, corrected QT, and T-axis. Adding those ECG features to a clinical model improved the C statistics from 0.70 to 0.73 in the test set, with modest gains on reclassification and integrated discrimination improvement. The strongest clinical predictors were a history of arrhythmia, valvular disease, and diabetes, with hazard ratios between 1.4 and 1.6. The heart rate variability parameters, STNN, RMSSD, PNN50, were uniformly low across the cohort, consistent with dysautonomia in CKD. But they didn't add independent predictive value once the standard ECG features were already in the model. This is a single-center electronic health record-based cohort, so misclassification of comorbidities and outcomes is always a concern. ECGs were performed as part of routine clinical care rather than systematically, which introduces selection bias. And the lower heart failure risk we saw when screening indication ECGs probably reflects residual confounding. The heart rate variability measurement is the most important caveat to mention here. We derived HRV from 10-second ECG tracings, which is much shorter than a Holter, and the values were severely depressed across the whole cohort. We may be running into a floor effect, where the dynamic range simply isn't there to detect associations. External validation in independent CKD cohorts is essential before any of this is clinically actionable. The data tells us that 3 standard ECG features, PR interval, QTC, and T-axis, carry information about future heart failure risk in CKD that standard clinical variables don't fully capture. That said, the improvement in discrimination is modest and at about 3 points of C statistic, and we haven't externally validated yet. So this isn't ready to change management today. The path forward is external validation in independent CKD cohorts, head-to-head comparison with existing scores like the Crick heart failure score, and ultimately trials testing whether ECG-based risk stratification paired with prophylactic therapy or closer monitoring actually improves outcomes. In the meantime, I think of these features as a low-cost flag worth noticing on the ECGs we are already ordering. The no finding for the heart rate variability is worth a quick note. It doesn't mean autonomic function is irrelevant to heart failure risk in CKD. Heart rate variability was severely reduced across the whole cohort, leaving very little room to detect differences between people. I would read this null as a limit on our ECG-derived heart rate variability measurement and not a reflection of the underlying pathophysiology. Thank you for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.